Hi, everyone. I'm Steve Lubinsky. I'm a clinical associate professor at NYU. I'm medical director of respiratory care at NYU. And I want to thank the organizers for giving me the opportunity to talk to you about this topic. And thank you all for your attention. I have no conflicts of interest relevant to this discussion. However, I must disclose that I have worn the helmet and lived to tell about it. Finally, a word on regulatory considerations. The experience with helmet ventilation in the United States is very limited compared to Europe because helmet ventilation interfaces have not been available in the United States. However, under the FDA EUA for ventilators and ventilator accessories due to the COVID-19 pandemic, several of these devices, as of this recording, are available in the United States. And I would refer anyone interested in that, the specifics of that, to the FDA for more information. So I'll discuss the nuts and bolts and specific considerations around helmet ventilation. What is it? How is it administered? What are some of the major differences between helmet and face mask ventilation? Briefly, discussion about acute hypercapnic respiratory failure, and then in a bit more detail, acute hypoxemic respiratory failure. So what is helmet ventilation? So the essential elements of the interface are a hood, which is a clear plastic bubble, inspiratory and expiratory connectors for gas limbs, inspiratory and expiratory gas limbs, a flexible collar that makes a seal at the neck and allows for positive pressure ventilation, and then underarm straps that secure the interface during treatment because it's pressurized and will tend to lift up with positive pressure. Variable between devices are patient access ports and other accessories that may improve the comfort during treatment. How does it work and how is it set up? So this is Mauricio Serreta. He is a critical care anesthesiologist and helmet ventilation expert at the University of Pennsylvania. He is modeling the simplest setup for helmet CPAP, which is a high flow gas blender and a PEEP valve. So the high flow blender sets the flow rate and the FiO2, and the PEEP valve sets the CPAP level. There will always be a filter on the expiratory limb. There's often also a filter on the inspiratory limb to diffuse some of this flow and diminish noise, make the treatment more comfortable. These are usually not humidified to decrease the potential for fog and rainout during therapy. Helmet CPAP, as well as helmet bilevel ventilation, can be provided with a double limb ICU ventilator as diagrammed here. So in that case, the inspiratory and expiratory ports on the helmet will be connected to those limbs on the ventilator. The ventilator can be set in non-invasive mode, which may help with compensating for leaks through the system. But most important is to have direct access to the trigger and rise time. Because of the volume of the helmet, the trigger and delay in the trigger is really tangible. So the trigger is usually minimized or made as sensitive as possible to without auto triggering to improve synchrony. Similarly, the rise time is usually minimized to improve synchrony and comfort during therapy. This is video from Bhakti Patel, John Kress, and Jerry Hall's clinical trial at the University of Chicago. And so the donning and doffing process, they'll show their procedure during their trial. So they've measured the patient to fit the helmet. They're finishing assembly steps for the device that they used in their trial, attaching it to the ventilator, setting the ventilator, and we'll get into their protocol later. Note that it takes 2 people and 4 hands to stretch the collar so that it can be kind of popped over the head, and that the patient was cooperative and maintained his posture to help them to do that. He has a hand on the top of the helmet to hold it in place as they start therapy and attach the underarm straps to secure the interface. Here he is being ventilated, so you'll see the system inflate and deflate slightly as he triggers and is receiving therapy. So the helmet is of a large volume, usually greater than 10 liters, and that's different than other respiratory care devices. It's closed, it's flexible. So when a patient is being ventilated, the volume of gas, the minute ventilation and tidal volume delivered to that system is not, and what's measured by the ventilator is not necessarily equal to the breath size taken by the patient. The patient will be getting a fraction of the total gas flow and tidal volume delivered during helmet non-invasive ventilation. Because of the large size of the helmet, there's also a greater risk or greater consideration for the risk of CO2 rebreathing than with face mask ventilation. This can be addressed in a number of ways. People have added supplemental flow lines, they've added leak to the system, but the most common and probably simplest way to manage this is to increase the overall flow rate through the system during therapy. So this is a model system of a styrofoam head and helmet ventilation setup showing percent CO2 in the helmet and overall minute ventilation through the system. The solid lines are predicted or calculated percent CO2 at different VCO2 levels and flow rates. The dots are what was measured when they inflated the system, and you can see that at lower flow rates there was increases in percent CO2 in the system. Similarly, in healthy volunteers on face mask ventilation, then decreasing flow rates of helmet CPAP, there was a significant increase in inspiratory CO2 as there was a decrease in overall flow rate. And at the lowest flow rates, there was also increases in end tidal CO2, tidal volume, and minute ventilation. Another difference between face mask and helmet ventilation is there may be a greater possibility for access to nutrition during helmet NIV therapy. So patients may be able to drink through a straw during therapy. That's shown here. This requires coordination of those steps because the helmet is pressurized with respect to the room. Using a straw is basically sort of a backward set of steps than you would typically use to drink liquid. More commonly, however, is just the use of a nasogastric feeding tube as shown. So let's talk about acute hypercapnic respiratory failure. So this is a relatively recent multi-center randomized controlled trial that looked at patients with acute hypercapnic respiratory failure due to COPD and randomized them to face mask and face mask or helmet ventilation, and looked at the changes in arterial blood gas at 1 and 6 hours after the initiation of NIV treatment, as well as dyspnea scores, vital signs, and clinical endpoints, outcomes. This study found that there was a similar change in pH, PaCO2, respiratory rate in patients who got helmet or face mask ventilation, and that the overall outcomes were also similar. A small number of patients in this study were intubated, 2 in the face mask group, none in the helmet group. There was a bit more complaint of noise in the helmet group, and the interface was changed twice in the helmet group and once in the face mask group. An even more recent meta-analysis of small studies of helmet ventilation in hypercapnic respiratory failure found that the ability to remove CO2 or decrease the PaCO2 was greater in patients who got face mask ventilation, or this analysis favored face mask ventilation, with one study being neutral. They also looked at risk for endotracheal intubation and found the opposite, that it favored helmet ventilation. But I would point out these are all small studies with small numbers of events. And if you look closely, this one, Antonaglia 2011, with the greatest difference, 7 of those 9 who were intubated in the face mask group were intubated for discomfort with that interface. So it may be more fair to say that helmet ventilation has been used to treat acute hypercapnic failure, respiratory failure, then that it is superior to face mask ventilation. All right, there's a bit more interest and data around the use of helmet ventilation for acute hypoxemic respiratory failure. So this is a small crossover physiology study of 15 patients with acute hypoxemic respiratory failure due to primarily pneumonia, receiving on average 50% FiO2. They spent time on face mask, high flow nasal cannula, and helmet ventilation. During treatment with helmet ventilation, there was improved oxygenation, improved respiratory rate, and improved visual analog scale for dyspnea. These patients also had esophageal balloons in place during therapy, and despite higher airway pressures during helmet ventilation, there was no significant difference in transpulmonary pressure and significant decreases in change in esophageal pressure and esophageal pressure time product. Okay. The sort of landmark clinical trial for helmet ventilation and hypoxemic respiratory failure is the clinical trial from the University of Chicago, which randomized, was a single center study that randomized patients with ARDS to either face mask ventilation or helmet ventilation, using a similar protocol in each group around the PEEP and inspiratory pressure. The helmet group had additional considerations around peak flow rate and pressurization time for the considerations that I'd mentioned earlier. Their primary endpoint was the proportion of endotracheal intubation, and they had a predefined criteria for that. Secondary endpoints were 28-day mortality, ventilator-free days, ICU, and hospital length of stay. The most common reason for hypoxemic respiratory failure was pneumonia, and the second most common reason was pneumonia due to immune suppression. These patients were on a median 60% FiO2 at study entry in both groups. Patients randomized to the helmet in this trial had a significantly lower rate of endotracheal intubation, significantly more ventilator-free days, less ICU days, and improved inpatient and 90-day mortality, hospital and 90-day mortality. There were 3 pressure injuries in each group, and in the helmet group, these were relocated from the face to the under the arms and the collar. They tracked their outcomes of these patients at hospital discharge and at 1 year, and found that patients in the face mask group were weaker when they were discharged, had a higher mortality out to 1 year, and a lower functional independence as well. Helmet ventilation has been widely used in COVID units and ICUs in Europe. A large, relatively for this, clinical trial, randomized controlled trial of helmet ventilation versus high flow nasal cannula in Italy randomized patients with acute hypoxemic respiratory failure due to COVID-19 to continuous initial treatment for 48 hours with high flow nasal cannula or helmet ventilation. The primary endpoint was days free from respiratory support by day 28, and their secondary endpoints were endotracheal intubation, ventilator-free days, and ICU mortality and length of stay. They had a predefined criteria for intubation as well. This was negative with respect to the primary endpoint of respiratory support free days. There was no difference in mortality. However, patients randomized to the helmet in this study also had a lower risk rate of endotracheal intubation and more ventilator-free days. A very recent letter in the Blue Journal presented a post hoc reanalysis of this data around the endpoint of endotracheal intubation, looking at baseline respiratory variables. This found that patients with a lower or PCO2 lower than 35 had a lower risk for endotracheal intubation when they were randomized to the helmet. They also looked at, this is oxygenation, a combination index of oxygenation and dyspnea. So PaO2 to FiO2 times visual analog scale for dyspnea, with a lower number being more dyspnea and more hypoxemia. And so patients with a sort of more dyspneic, more hypoxemic measure similarly were less likely to be intubated when randomized to the helmet, or those that were randomized to the helmet had a lower risk of intubation. Awake prone body position has been used during helmet ventilation treatment. It was not used in helmet ventilated patients in the prior study, but there are several small studies that have looked at patients being treated with this in the ICU and outside the ICU environment, shown that basically that it was done successfully and that there was increases safely, and that there were increases in oxygenation and decreases in respiratory rate while in the prone position. So what are some advantages of helmet ventilation? What do we take away? So it may be more comfortable than face mask ventilation. There are potential physiologic benefits around oxygenation, work of breathing, dyspnea, and it is possible to administer a higher airway pressure with less leak than with face mask ventilation. There's less risk of facial pressure injuries. There may be a greater access to nutrition during therapy. And when it's up and running, there's can be very little or no gas leak. What are some challenges and potential disadvantages? So the helmet interface is different enough from the face mask interface that it requires a significant learning curve for a multidisciplinary team to implement. And it does require more people to start and stop therapy than the other non-invasive respiratory support options. Monitoring is a challenge. So if there's a concern for a risk of ventilator-induced lung injury on an individual basis, it's not possible or easily possible to measure the patient's tidal volume during therapy. What if the patient needs an upper body central line? What if the patient needs nebulizers? These are limited during therapy because of the location of the treatment and the way it delivers positive pressure ventilation. Infection control when the therapy is being run continuously is probably quite good, but during donning and doffing of the helmet or when accessing the patient access ports, there may be a large amount of unfiltered gas leak. In contrast to high flow nasal cannula or non-invasive ventilation that have a body of literature around pre-oxygenation for intubation, the helmet doesn't really have that, and adds more the challenge of coordinating doffing it to manipulate the airway. Potential complications include noise. There is or has been raised the concern for potential of tympanic membrane injury. When the helmet pressurizes, it feels like an airplane liftoff, basically. I have not seen any cases of that, but that's a potential concern. Pressure injuries are redistributed to the neck, to basically the touch points of the interface under the arms and at the neck. And then upper extremity DVTs have been reported. There was one in the Italian randomized control trial, and then there have been others in patients with COVID-19 in case report form. So back to the title, to the question, is there a space for helmet ventilation in the modern ICU? So for acute hypercapnic respiratory failure, it's probably less efficient for CO2 elimination than face mask ventilation, and we really lack large high quality studies around clinical outcomes. In acute hypoxemic respiratory failure, we have some promising data. However, we have one single center randomized control trial enriched in immune suppressed patients comparing the helmet to face mask ventilation, and another comparing the helmet with high flow nasal cannula in COVID-19 that was negative with respect to its primary endpoint. In light of the recovery respiratory support results, we might have questions about the role for, or relative roles for high flow nasal cannula versus face mask CPAP versus helmet non-invasive ventilation. as the initial therapy in acute hypoxemic respiratory failure due to COVID-19. We really don't have comparative, prospective comparative evidence to guide us there. And then, we raised the question that there may be subgroups by etiology, by physiology, who may have a benefit from one of these options, potentially from helmet ventilation. So with that, I'd like to acknowledge the team at NYU, my friends and colleagues in the pulmonary critical care department, my partners in the respiratory care department, and thank you all for listening, and I'm sure there will be time for questions.